What is going on, everybody? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my EMT EMS playlist. In previous videos, we talked about the vital signs, the physical exam, the levels of consciousness, and the Glasgow Coma Scale. Today, we'll learn about how to examine a patient in an emergency situation from head to toe. We will examine the head and the neck. We will examine the cranial nerves and the pupils. We will look for signs of trauma. We will also look for signs of fractured base of the skull or basilar skull fracture. Then we're going to examine the chest, the abdomen, the pelvis, as well as the upper extremities and the lower extremities. And as always, we have practice questions. Click the like button, click the subscribe button, and let's get started. This is my emergency medical services playlist. Please watch these videos in order for maximum understanding and retention. Not to be confused with atropine's urinary retention. Enough with these dad jokes. How do we assess the patient in an emergency situation? Look at the scene. Is it safe or not? How many patients are there? Ask the patients and the bystanders. Is it a medical case like a myocardial infarction or a stroke, or is it a trauma case? Always start with the ABCs, airway, breathing, and circulation. After the scene, look at the patient's age, sex, appearance, pregnant or not. Introduce yourself. And then ask the patient, what's your name? Is the patient conscious and responsive? If the answer is yes, the odds are the ABCs are okay, but you need to check them as well. But if the answer is no, my patient is not conscious, not responsive, then of course you check the ABCs. If the airway is closed, you open it. If there is apnea, you ventilate. And if there is no pulse, you start the CPR, which is cardiopulmonary resuscitation. Check the vital signs: pulse, blood pressure, respiratory rate, and temperature. Is the temperature normal, or do we have hyperthermia or hypothermia? Is the respiratory rate okay, or do we have tachypnea or bradypnea? Is the blood pressure okay, or do we have hypertension or hypotension? Is the pulse okay? The pulse has many aspects. One of them is the heart rate. Do we have normal heart rate, or do we have tachycardia or bradycardia? And then, transport priority. Stay and play versus grab and go. If it's something minor that can be treated on the spot, then we treat it, and that's it. But if it's something major that requires going to the hospital, then we're going to load the patient on a stretcher, put the patient in the ambulance, and go to the hospital quickly. How do we know if the patient requires to go to the hospital? Here are some classic scenarios. The patient is unresponsive and there is no gag reflex. Or the patient is responsive but cannot follow commands. Or it's complicated childbirth. Or there is severe pain, severe bleeding, shortness of breath, and shock. Use the sample acronym to guide you. S for signs and symptoms, A for allergies, M for medications, P is for present medical history, L is for last oral intake, for example, the last meal, and what was the last meal, when was it, and what was the food, and the events that led to the episode. Everyone knows the ABCs, airway, breathing, and circulation. But some people forget about the D's and the T's. The D's, drugs. T, temperature. Hey. What's the difference between airway and breathing? Airway is the anatomy. Is the anatomy open? But breathing is the physiology. It's breathing in oxygen and breathing out carbon dioxide and gas exchange. In most cases, if the patient is talking to you in a normal, calm tone, in no distress, then probably the ABCs are fine and intact. However, this can change in a second. Just because the patient is okay right now doesn't necessarily mean that the patient is going to be okay 5 minutes from now. And that's why we always need to check and recheck and recheck and re-examine again and again and again. If you want to see more videos like this in the future, please drop a fire emoji in the comments. What are the levels of consciousness? There are many systems that you can use. Here are just two of them. One is conscious, well, that's the best, that's normal. Then I deteriorate into confused, and then delirious, and then somnolent, and then obtunded, and then stuporous, and then comatose. Another system goes like this: alert, response to verbal stimuli, response to painful stimuli, and unconscious, which is the worst. So this is the AVPU system. And then there are some scores, such as the famous Glasgow Coma Scale. which I've talked about in detail in a separate video, which you can find in this EMS playlist. And that's why you should watch the videos in order. The vital signs were also discussed before in detail. And in my video on the physical exam, I've taught you how to examine the pupils. What does it mean if the pupils are dilated? What if they're constricted? What if they are not responsive to light? What if one is bigger than the other? All of this was discussed in the physical exam video. Also, skin examination was mentioned there. Now, from head to toe examination. For the head, examine the cranial nerves. Of course, it's hard to examine all of them in an emergency situation, but here are the ones that you should examine. Cranial nerve 1 is the olfactory nerve. So if you have something that has a characteristic smell, you can ask the patient to smell it to make sure that the olfactory nerve is intact. The second cranial nerve is the optic nerve. You can ask the patient to count your fingers. My dear patients, how many fingers are these? The answer is 2. If the patient can say that, the optic nerve is probably intact. But you need to do this on the right eye first and then the left eye, or vice versa. But you have to examine the eyes individually, because I can see 2 fingers even if one of my eyes is totally blind. And then 3, 4, and 6 are examined together through the eye movements. So you ask the patient to follow your finger as you make an H pattern. Look up, look down, look to the left, to the right, everywhere. And you can do this for both eyes together, but you need to examine both eyes. Cranial nerve 5 is the trigeminal nerve. This is for sensations on the face. Dear patient, close your eyes. All right, can you feel this? Well, that's on the right. All right, now, can you feel this? Yes. But even better than asking your patient, can you feel this, is to tell the patient, hey, when I touch you, say, I feel it. So when you touch the patient, we'll say, I feel it. But what if the patient cannot feel this area? Then if you touch the patient will say nothing. And that's when you know there is something going on. 7 is the facial nerve. Can you smile for me? Can you raise your eyebrows? Can you wrinkle your forehead? 8 is the auditory nerve. That's for hearing. So you make some noise with your fingers near the patient's left ear. Can you hear this? How about the right ear? Can you hear this? Close your eyes and then you make some noise closer to one of the ears. And you ask the patient, did you hear this louder on the left side or on the right side? 9 and 10 can be examined via the gag reflex. If the gag reflex is intact, 9 and 10 are intact. 11 is the accessory nerve, to shrug your shoulder and look to the other side. If the patient can shrug both shoulders, 11 is intact. Also, look to the right and look to the left. Turn your head to the right and turn your head to the left. Not just your eyes, it has to be the entire head. And 12 is the hypoglossal nerve, and that's for tongue movements. Stick your tongue out, move it to the right, move it to the left, move it up, move it down. Then 12 is intact if the patient's movements are normal. Then you examine the patients for signs of trauma. The signs of basilar skull fracture were discussed in a separate video, but these are the most common ones. Raccoon eyes, what are these? Purplish or black discoloration around the eye orbits. Next, the purplish or black discoloration behind the ear, known as Battle's sign. Another sign is cranial nerve abnormalities. That's why we examine the cranial nerves. Another sign of basilar skull fracture is fluid oozing out. What kind of fluid? Cerebrospinal fluid, which is a clear fluid. It's not pus. Pus is very thick. Pus is very turbid. It's not clear. But cerebrospinal fluid is clear. The CSF can be coming out of the nose, and this is called CSF rhinorrhea. The CSF could be oozing out of the ears, otorrhea. There could be blood in the external auditory canal, and there are many other signs of basilar skull fracture. We talked about examining the pupils before in detail, so please refer to my previous video titled Physical Exam. Then, you examine the conjunctiva of the eye. The conjunctiva lines the eyelids from the inside, and it also covers the sclera from the outside, but it does not cover the cornea. Look for subconjunctival hemorrhage and or hyphema. Subconjunctival hemorrhage is seen on the outside. To make it easy, look at this white of the eye, which is the sclera. If you find blood here, that's probably subconjunctival hemorrhage. But if you find a level of blood inside, like this is called hyphema. Look for foreign bodies near the eye, at the eye, or the face. Look for signs of trauma, such as abrasions, contusions, and lacerations. Is there any bleeding anywhere? Do we have any broken teeth or even loose teeth? This is a sign of trauma. Do we have any abnormal odor? This could be a sign of infection or foreign body. After examining the face, we examine the neck. Is the trachea in the midline? It should be in the midline. You examine the trachea by sticking 2 fingers in the suprasternal notch. What if the trachea is shifted? Well, pneumothorax, especially tension pneumothorax, is going to shift the trachea to the opposite side. For example, if I have tension pneumothorax around the right lung, the trachea will be shifted towards the left side, which is the opposite side. But if I have atelectasis, which is collapse of the lung, suppose that the atelectasis is on the right side, then as the lung shrinks, it is going to pull the trachea towards it, so towards the right side, which is the same side as the atelectasis. Then you examine the jugular veins. Which jugular vein am I examining? Internal jugular or external jugular? The answer is internal jugular vein. On the right side or on the left side, it's easier to examine the right. And it's better to examine the right side. Jugular venous distension, where the right internal jugular is distended with blood, can be seen in pneumothorax, especially tension pneumothorax, right-sided heart failure, right-sided myocardial infarction, and cardiac tamponade. To learn more about heart failure, MI, and cardiac tamponade, see my cardiology playlist. To learn more about tension pneumothorax, check my pulmonology playlist. Next, bubbles. When you put your fingers on the patient's skin and press, you'll feel air bubbles. And they are usually painless. What is this? This could be happening because of trauma to the trachea or trauma to the chest wall. Trauma to the trachea will lead to air escaping the airways and going to the subcutaneous tissue under the skin. And these are the air bubbles that you're feeling. But this could also be caused by a doofus doctor, by misplacing the chest tube, puncturing something, or barotrauma from mechanical ventilation. Also, while examining the neck, look for fractured ribs, because trauma can also lead to fractured ribs. The chest or the thorax, we're going to look for fractured ribs or rib fracture. Rib fracture is usually painful, so when you press your fingers on it, the patient feels the pain, unlike the subcutaneous emphysema, which is usually painless. Next, the flail segment. What is that flail segment? Flail segment is when the part of the chest is effed up. What does that mean? Paradoxical movement. What does that mean? Well, normally during inspiration or inhalation, the chest expands. And during expiration or exhalation, the chest wall shrinks. However, in some cases of trauma, such as rib fractures, suppose that I have fractured 2 or 3 ribs in this segment can go crazy, can go the opposite of the entire chest wall. So during inspiration, the entire chest wall is expanding, which is normal, except this tiny segment that has the fracture, which is shrinking inwards during inspiration. Conversely, during expiration, the entire chest wall is shrinking in, except this flail segment, which is bulging out. And this is when the thorax knew that it effed up. Tension pneumothorax can do what? It can lead to jugular venous distension. It can push the trachea towards the opposite side. And on the site of the tension pneumothorax, you can feel hyperresonant percussion. What is this? Suppose that the tension pneumothorax is on the left side. Then it means that the left pleura is filled with air, because air is coming from the outside after trauma. Air is coming in from the outside, but air is not leaving, and this is the valve-like mechanism. Just like the valve on the tires of your car. It allows air to go in, but not out. And if air keeps piling in and in and in, the pleural cavity will expand, causing lots of tension. This tension is caused by air. So if you tap your fingers on the patient's chest, you'll feel tons of air. If a cavity has lots of air, it is hyperresonant to percussion. If it does not have any air, it is dull to percussion. But what's the normal percussion node in the thorax? The normal is resonant, not hyperresonant. If you want to feel the resonant percussion node, simply tap the sides of your chest, where the lungs are. You will feel the resonance. If you want to feel the dull percussion node, simply tap your scalp. The scalp is dull to percussion because there is no air inside, I hope not. Honestly, judging by the level of competence of my students these days, I need to examine their skulls for subcranial emphysema because some of them have an amoeba for a brain. Examining the abdomen. If the patient has abdominal aortic aneurysm, we expect abnormal pulsations around the umbilicus. Sometimes they are visual without doing anything, but sometimes you need to feel them and provoke them, and to do this, get both of your hands ready, and I want you to use the edge of your hand, the left one and the right one, like this, and you're going to compress the skin around the umbilicus, right and left. And you push both edges of both hands inwards, and this will make you see those pulsations. Abdominal aortic aneurysm is a big deal because if it ruptures, the patient is toast. Make sure, of course, to palpate the 4 quadrants of the abdomen. For the anatomy buffs out there, remember that the abdomen has 4 quadrants, because that's what the word quadrant means. It's a quota, so of course it has 4 quotas. However, the abdomen has 9 regions, so that's a different classification. The 9 regions are, where there is stomach, there is epigastrium. Where there is umbilicus, there is umbilical region. And below that, there is hypogastric. And then there is the right rib cage here, so right hypochondrium, or below the costal cartilage. And on the left, left hypochondrium. And then on the sides of the umbilical, you have right lumbar and left lumbar. On both sides of the hypogastric, there is right iliac. Does anyone remember the iliac crest and the iliac fossa? And the left iliac. As for the 4 abdominal quadrants, they include right upper quadrant, left upper quadrant, right lower, and left lower quadrants. Then examine the pelvis, including the genitalia. Why? Because there could be bleeding there. This can happen after trauma. Priapism is sustained erection of the male organ that is not going away anytime soon. This can lead to necrosis or death of the male organ. That's an emergency. Make sure that the patient's pelvis is stable. How do you do this? With your left hand, you push on that iliac crest backwards and see if it's stable or not. It should not be pushed. It should remain stable and resist your pushing. However, if you found it loose, like the old door in your grandma's house, that's a problem. This is pelvic instability. And you repeat the same thing using your right hand onto the patient's left side of the pelvis. Then you examine the extremities, the upper extremities and the lower extremities. Examine what? The neurovascular bundle. Neuro means nervous system, motor and sensory. How do you examine the motor? You can ask the patient to move the arm or move the leg, if the patient can do it. You can simply squeeze the muscles. Can you feel muscles? Or is everything atrophied? Sensations. Do your patient close your eyes and then say, I feel it whenever I touch you? Vascular examination. You examine the arterial pulse, as we have discussed in previous videos in this playlist, and you examine the capillary refill, also discussed before. Don't forget to examine the back of the patient before you put the patient on a stretcher. There could be injury, there could be bleeding, there could be ecchymosis, there could be an abscess, there could be many other abnormal findings. Just because your patient is stable now doesn't necessarily mean that the patient is going to be stable 5 minutes from now. This can change very quickly, and that's why it's paramount to recheck the vital signs every 5 minutes, especially if the patient is unstable. Re-perform the physical examination if the situation changes. Document, 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 document. Prepare your pre-hospital care report, whether it's in paper form or electronic. The electronic pre-hospital care report is called ePCR, which stands for pre-hospital care report, but it's a cute name because it can also stand for polymerase chain reaction. What should I document? Everything. Today's date, the patient's name and address and phone number, male or female, date of birth, medical history, medications that the patient is taking. Is the patient allergic to anything? The physical exam findings. If you provided any treatment, document it. Then the patient will sign and you will sign. Quiz time. Which of the following respiratory rates in a neonate is concerning for difficulty breathing? Is it A, B, C, D, E, or F? Let me know your answer in the comments. You will find the answer key in the next video in this EMS playlist. If you want to take your emergency medicine knowledge to the next level, if you want to learn about strokes, myocardial infarction, cardiac arrhythmias, ARDS, acute limb ischemia, drowning all the toxidromes that you can imagine, download my emergency medicine high yields course at medicosisperfectionalis.com. It comes with videos, notes, and cases. Help me make more videos by supporting my channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.